So we come on to our next part. We have smell training debate. Quite a dramatic title. And we have our debaters up here, Carl and Steve, around the subject of smell training. We've got a second part, which is smell testing, which Steve will cover towards the end of this discussion. Now, we're sort of setting up this debate, even though these two don't fundamentally disagree about it, but it's just to open up and explore the subject of smell training, because it is perhaps more complex than it might first seem, and also our relationship can be a very, very powerful one if we're trying to really look for a cure. So can I ask you both for sort of opening statements? Steve, if I come to you first, opening statement, your opening thoughts around smell training.
Okay, well, brief context is, a lot of my involvement with Fifth Sense has in part been in trying to play a role of helping the charity and helping people that understand the state of the science and where we are to get real information, because lots of times in the popular press or in Facebook groups and other things, some incorrect or unsubstantiated information comes through. And with smell training, I think, especially in this last couple of years, sometimes things are either overstated or misstated about what it is and where it might work, what the scientific basis is. And so that's something I think we just want to discuss some and be cautious about.
Carl?
Yeah, so smell training is a tool we can use in rehabilitation, and rightly it doesn't work for everybody. It's something that I will talk to patients about, and there's a good evidence base for using it in different causation groups, but there is still work to be done, particularly around COVID. So that's something that we need to put some more evidence and science behind. And I think the other thing is that there's often a fixation with using the original 4 odors, and so it's sort of having a conversation about actually smell training is about doing what's right for you. It's a personal thing rather than a sort of a diktat, and sort of trying to open up that conversation really.
Yeah, I think that's actually a good point to start on. So some of the original studies had used 4 specific odors, and it was eucalyptus, clove, and a couple others, and often doing so in the context of essential oils. So first of all, essential oils, that aspect of it has nothing to do with smell training. The reason essential oils were selected is because the oils can have very concentrated odors that are very stable and are nice, convenient jars over time. So if one is trying smell training and doing it with a scented soap and a mild spice and other things in your own home, that is perfectly fine. Those 4 odors, there's nothing unique or specific about them, nor is that concept of exactly how you're getting it. You want to avoid ammonia or bleach, something that's potentially toxic. Don't try that, even though they may be strong smells. And you also want to avoid using spices that may be more intense because of their chemesthetic aspect. We talked about that before. Because if you're smelling cinnamon and you're getting sort of a tingly burning sensation, that's not smell, that's the chemesthesis. It's still a relevant sensory input, but if we're talking about smell specifically, it's not. So scented soaps are a great way to do it. Some milder spices like an oregano or basil or something are things that you can have in your home. It shouldn't cost you anything to do this, anything more than you're already spending.
Yeah, absolutely. I mean, that's the thing. It's if there are things in your cupboards at home that can help with this, that's a key message. And as you rightly said, I mean, of the original 4, the eucalyptol, often people will say they've tried it and then gone, well, I'm smelling something, but and actually they're getting the chemical sensation, the trigeminal stimulation from that. So yeah, and whilst that can be helpful in itself, it's not obviously a smell sensation they're getting from it. So I think one of the things is it's about sort of coming back to understanding sort of talking about smell testing, which is I guess the other thing on the slide there. There's a familiarity that you have to have in order to go through smell testing, and some of that's cultural. And when you're doing identification tests, it requires a verbalization and a familiarity what the odor is. So with smell training, obviously, if you take something that's completely kind of random that you've never smelled before, actually it's slightly out of context. So the best thing is really to kind of work with things that you've actually experienced previously. If you're someone who's been able to smell previously, then going back to things that you were familiar with. Because it's not about trying to say guess what it is. It's about the stimulation process that's the important bit.
So that brings up one major question that goes along with it, and we'll leave aside for a moment the does it work at all, or does it work for certain people or cases or causes, and that is, how is it thought to work? And the short answer is no one knows. The broader answer is there are a couple possibilities that are most thought of. One is that by stimulating the olfactory tissues and some remaining tissue that is there and is still connected to the brain, is that you're strengthening connections. You're using the plasticity, the flexibility of the brain to augment some aspect of the olfactory system. Of course, this would imply that you must have at least some sensors still there, some connections to the brain. If you don't have an olfactory bulb, you were born without an olfactory bulb, or you have a completely severed and scarred over olfactory nerve from head trauma, this would argue that smell training is much less likely to conceptually work. The second possibility is that it is particularly relevant for people who are hyposmic, who have some residual function, and it is just like learning to throw a ball or learning to ride a bike or anything else, where with practice and attention you are able to best sort of engage the remaining function you have to use it most optimally. And so that's another possibility of what could be happening in the context of smell training. Oh, so
apologies for that. Just a real basic.
Well, in a nutshell, the original work was around taking those four odors that Steve mentioned and just spending a couple of minutes with each one under the nose to sort of to sniff and to smell, to see if you could perceive anything. And that was a twice daily sort of action over a 12-week period. The subsequent studies that followed on looked at modified olfactory training, whereas after the 12 weeks you changed to the different 4 smells, and then another 12 weeks on changed to a different 4 smells, so that you kept moving on from the original 4. And the studies showed that actually the kind of improvement in the modified technique was greater than if you just stuck with the same 4 odors for a 6 or 9 month period.
Yeah, and so that does bring up the point that the protocols that were developed as part of Originalist suggest many weeks of repeated stimulation, and I think there's the evidence of a particular time frame is probably not incredibly strong. There have been some significant ones, a few that have been tried at different parameters, but no one has really gone in and taken thin slices of exactly what's been done. Another challenge with interpreting the effectiveness of doing smell training is trying to differentiate it from just natural occurring recovery that happens for a lot of people, especially in the post-viral case, because as we certainly see illustrated very publicly with COVID-19, there are people who lose their sense of smell with COVID-19 and gain it back in a few days or a couple of weeks. There are others that show recovery over weeks to months, and then unfortunately there's some who have yet to recover even over a year later. But that recovery process for many happens, and if one is doing smell training at the same time, this is the idea of what is done in clinical trials. The gold standard is a double-blind clinical trial where the person doesn't know what they're getting, and of course that's hard to do in the context of when you're sticking a smell right in front of your face. You know that you're doing it. So how do we know that it's a for the people who show improved sense of smell that it is because of the training versus they would have recovered anyway. And that's been hard to differentiate and really lock down. And that's some of the lack of understanding that we have at the moment. Yeah.
Sorry, I'm mic on. So there's a lot of doubt in there, and this is an issue around evidence-based that we're talking about the doubt here. There isn't anything in here to say this is harmful.
Right, and so I would say in our clinic, and I think Carl would say the same thing, that especially with people with post-viral anosmia or hyposmia, it's often something suggests if someone wants to try, because as long as you're staying away from toxic chemicals, as your odors, it's not going to be harmful. It's worth trying. The concern, and this is what happens with science, as we build an evidence base and become more confident in what exactly how much stimulation would you need to do, in what is it only for people who are post-viral? Can it work for people who have other causes? Loss. These are types of things that we don't know yet. And so if we're taking and this is not an opposite because I think Carl has the same concern, one thing that worries me especially over the last couple of years, and we've seen this with government scientists, we've seen this in popular press, of people say, well, the only clear therapy that works is smell training. And that's, to me, is concerning, not because it might not indeed work, but because it gives a false amount of certainty that I think can be harmful. If someone feels, well, it's supposed to work for everybody who's lost their sense of smell, but it's not working for me, that is obviously an emotional toll it takes, and it is I think it's a lack of honesty about how it works. And I don't think this comes from the medical community, the people who are knowledgeable about it. I think it filters through more in the popular press and stuff. So it's important for anyone engaging in any therapy to know the level of certainty about it, whether it's a drug or training or anything else is I think where I think that caution is warranted.
Yeah,
So
I just to add that in the context of COVID, I mean there are some studies sort of ongoing, and we're hoping to do a further study too. So the evidence in COVID specifically is still being generated. We have something. I don't know if anyone's heard of Cochrane, but basically Cochrane is a sort of a resource that we use for gathering evidence, and we develop things called systematic reviews and meta-analysis, which basically means we look at a collection of studies and we analyse the results from all the different studies and pull them together to get a collective result. So we have something called a living review for prevention of smell dysfunction in COVID-19, and then another one for treatment of. And so far, when the team last did the check, there was basically one tiny study that had 20 people in it taking some steroid tablets and didn't really show a benefit. And that's about the only study that came up. So I know, looking on the trial registries, there's a few things sort of in the pipeline at the moment. But yes, there's still a big gap in the evidence base. And the key thing for COVID-19 is that we're still pretty early on in the process, really. I mean, the accepted wisdom for recovery from viral smell loss, even if you do nothing, is that the studies you've gone before suggest 1 in 3 people will get a spontaneous recovery in about a 3-year timeline. So we don't know, obviously, where that timeline will sort of head with COVID-19 specifically. So we're still gathering data, we're still understanding sort of the long-term effects of that.
So do people have any questions about the smell training and either anything we've said or something we haven't said you'd like to have addressed? Yeah.
A couple are coming in on Zoom while people are thinking on those. We had a question from Laura saying how often. I think you covered that as well. Sherry asks, have you ever had a client that did smell training and there was an improvement in retronasal but not orthonasal?
That's a good question. I mean, I guess the trouble is the resource to kind of test that all the time. I mean, we occasionally will do retronasal testing, but our sort of routine bit is normally at the beginning of the journey where we do the orthonasal testing with the sniffing sticks. So it's just a resource issue really when it comes to doing it in the clinic. Yeah. And I couldn't try and persuade our service managers to let me do retronasal testing.
Yeah,
I can see that being a sort of a HalfBased challenge.
Yeah, I mean there is a it's not as rigorous a test. There's a simple way to do it with just a chewy candy like a jelly bean. I mean, this sounds simplistic, but take a fruit flavored jelly bean and what do you all call them here?
Jelly bean will do.
Oh, okay. I know there's some other term, but and hold your nose tightly closed and chew, and if it's say a citrus flavored one, you'll be able to get the sourness of the acid, citric acid. You'll be able to get the sweetness of the sugar, but you wouldn't be able to tell if it's orange or lemon. And then open the nose, and that allows, because it's already in your mouth, it's not coming up from the front of your nose, it's coming from the back, that retronasal olfaction. People, I mean, you see people who have a functional retronasal smell will, I mean, the eyes will open, it'll just be, oh, wow. And it's quite dramatic. So that would be a simple way to assess if you feel that your smell is returning and you want to differentiate orthonasal versus retronasal smell. That's a and plus you get to eat your jelly bean, so it's everybody wins. Yeah.
Thank you. Claire asked a couple of questions. What are the recommended training smells again? Claire, the training smells are on the Fifth Sense website, aren't they? So there's a smell training page on the Fifth Sense website, but briefly those four are the four basic
Well,
smells.
I guess that's
the
the debate
classic
is
ones.
recommend. Those have been used before.
Those have
I would
been
say we
recommended.
wouldn't. They don't have to.
Don't have
they
to
would
be
be
those.
recommended. Yeah.
And I think the key thing is on the smellability page is that there are a range of things in the cupboard at home which you can try. So I think the idea is that you go and personalize it. Really.
So it's just avoiding anything, which even in the nicest way might irritate your nose. And we talked about cinnamon being one, anything which is,
Don't see your nose on the beach.
No.
Yeah.
And Claire, I think this is picked up from what you said earlier, Kate, is about any research or treatment is there to deal with parosmia. And I think you pulled up that. Was it you that said about the music? Was it about trying to, yes, okay, I'm just trying to remember. Yeah, on top of it. That was such a clear explanation of the experience. Any experiences with parosmia, which is such a big issue post-COVID?
Certainly, there's experience with a lot of people reporting it. Especially post-COVID, oftentimes it seems to be to emerge well after, even after the anosmia may have resolved. The parosmia does. And for many, it seems to be temporary. I don't know if you're finding the same. We don't know what causes parosmia. That's part of the problem. We can speculate that it's as the system's trying to repair itself, the brain is doing a poor job of making sense of that signals till everything gets sorted out, and so in that case can be a more temporary thing. But we don't have any specific treatment to recommend for it.
I mean, I think what I would say is that parosmia often comes in when you're getting to a stage of being hyposmic, and so the fact that you're smelling something even as distorted means that there's some functionality. So whilst I accept smell training in that context is going to be tough, that's why personalising is important, because if you're going with the diktat of the original four and they don't work for you, then that's problematic. But if you find things that actually you can tolerate and you're stimulating the sense of smell, then that's a good thing, because the fact you've got parosmia probably means you're on the sort of timeline of some sort of recovery. And the reality is that most parosmia is probably short-lived eventually, so it'll and that because usually there's sort of enough functionality comes back to kind of take the edge away from it. But again, for COVID, we don't know how that pans out at the moment because we're still learning about it. The context there is viruses that have gone before, and we know how that's usually worked in previous viruses.
On this subject, Charlie, yeah.
Yes. Sorry, you mentioned that you were going to go over what kind of causes it helps, and I was wondering.
I don't think we have clear evidence for that, but I would say the best evidence, and Carl, I think you agree with this, is in the case of post-viral anosmia, hyposmia, and I would say the evidence for it having any effect in the case of congenital or post-traumatic brain injury is that it's rarely been seemed to have any effect.
Yeah, there was one study done by Jordanis Konstantinos in Greece on post-traumatic cases, and that did show some patients benefited. And one of the problems often with, we talk about causation groups, but within each causation group there's a spectrum, and head injury is a particular one because there are different levels at which the injury can occur. It might be at the level of the olfactory nerves, it might be the olfactory bulb, it might be the brain tissue at the end of the process. And so depending on where your injury occurs on that level, or whether you've got multiple injuries along that level, may depend on your ability and or the chances of smell training being a potential benefit. There is some thought that the olfactory nerve fibers may regrow over time, and that's why the longitudinal studies suggest that perhaps a third of patients post-head injury may get sort of recovery over a much longer time period. Generally there's a sector that's a kind of 2-year time period, which most people get recovery back, but then there's a tail, and there's this kind of small number of people who might get a slow recovery process. So one of the problems with a lot of the studies around smell disorders over the years is that they tend to kind of take in a group of smell disorders, chuck them all in together into one study, and then apply the same treatment. Yeah. And then you end up with this difficulty with, what really works for A, B, or C, because, we don't really know, because there were only 5 people with head injury and 5 people with viral smell loss. So, one of the things we need to do better in the future is to have studies dedicated to particular causation groups and enough evidence around the spectrum in that causation group of to what's really working.
So not a huge disagreement between you, but I guess, Carl, you sort of mentioned that piece around false certainty being an issue.
Yeah.
Just to pause on there a second, what is, because what we've got here is saying, well, you have some smells, you smell it, you've tried, it doesn't work, but actually that false certainty piece does flag up for me an area of concern. Open that up a little bit as to why that's an issue.
Well, I guess at the end of the day, what I would say is that if someone tries smell training and they find it to be, they find that they've had some recovery, I'm certainly not here to say, well, no, you're wrong. It didn't do anything for you. There's no point. I'm glad you have recovered for whatever reason that might be. The concern is giving someone a false certainty about it that may, if they don't see any recovery while doing smell training, that makes them maybe have too great an expectation, too great a certainty that it was going to, or feel like that they have failed or done it wrong, or someone contributed to it not working. I think there's a real risk of sending people down a bad path emotionally and with unrealistic expectations. That as scientists and physicians, we always try to be as straightforward and honest with people about what we know and what we don't know, and the likelihood. And I just think that it doesn't always come through when, especially in the popular press, things get simplified allegedly for clarity, but actually muddies the waters a little bit more.
And if you ask an expert, the chances are they'll say it's complicated.
Well,
and that's a very difficult one to hear. Yeah.
Which can be a very unsatisfying answer.
Yeah.
I realize that.
Absolutely.
So, but there are, and I think Carl mentioned this briefly, I know of at least one fairly large smell training clinical trial that's going on in the U.S. in Missouri right now, that I think they're going to be having results of that fairly soon. In the next couple months or so, we should be hearing some results of that. It is one study, and I don't know all the specifics of how it was arranged, but there are people starting to try to more rigorously test this, so we know whether it is viable, and if it is viable, for which patients it would be the most helpful.
And so the improvements on that would then come back into the way that clinicians, physicians are communicating as a real key point in what could come.
Absolutely.
Yeah, definitely.
Excellent. Thank you very much. We've got one extra piece in this, which is looking at smell testing.
Just we had a question about this earlier on about how one assess tests, and I thought it might be useful to talk about 3 ones. And Carl just mentioned in the point of our initial conversation. So smell identification is a very common test. There are card-based ones, scratch and sniff. There are in the sniff and sticks, these odor wands. What is it? Giving your choices. But you can imagine it. If you were born without the ability to smell, trying to choose between rubber tire and onion is a completely irrelevant choice, and it's meaningless. And that's maybe more extreme example. But imagine a child who just hasn't had as rich an olfactory experience, and maybe they have been able to smell but don't know turpentine, or don't know a shallot, or don't know some less common fruit. Commonly, these tests are used what we call monomolecular odorants, meaning it's a single chemical compound that is trying to represent what is a much more complex mixture of aromas. Banana is a very common one that is used, but the compound isoamyl acetate that is used is not prevalent in the bananas that we typically buy in the store, with a brand of type that's called Cavendish. Was very common back in the 30s and 40s in a banana that was the most common one that got almost completely wiped out by a blight. So it's real banana smell. It's just not what we're familiar with. It's more the banana candy or banana pudding that you will encounter. So it requires a certain amount of experiential knowledge, cultural specificity oftentimes. A lot of the tests that were made in the US had root beer, which in Europe people smell it like, what the hell is that? No concept. It's just a beverage that is just not common over here. And so there are limitations there. And for people who have a cognitive disability, whether it is something they're born with or developing neurodegenerative disease or something, there may be also problems with recalling names or speaking or doing things like that cause problems. The other two types of tests that are commonly used, or sometimes used in combination with that, are odor discrimination. Can you tell, are these two different? Do they have a different perceptual quality, or are they the same? And then threshold, how set with the same odor at different concentrations, how little concentration can you still detect? And so these can be used in combination. Those are the three that work together. However, in all of those, they require you to respond. We don't have, if we give you that test, we don't, and there's for some reason something else going on that doesn't allow you to respond in a way that conveys exactly what you're experiencing, that's a problem. So they are objective in some ways in that we put numbers on them and we get some rigor in that, but they aren't objective in that they require it to be filtered through your own experience and be able to relay it via language or pointing or something like that. So there's one lab in Sweden that recently developed a technique for humans. It's a technique that we use in research studies in a variety of ways, called electroolfactogram, where they can measure the electrical activity specifically coming from the olfactory bulb. And this would be something that, if incorporated into a much more user-friendly way in more clinics, could provide just like doing an electrocardiogram or an electroencephalogram for people getting assessed for epilepsy or such. This could be a very objective way of assessing whether someone is actually getting a odor signal back to the brain. For taste, which I know we don't talk as directly about as much, there are taste strips and other types of things, or small liquid aliquots you can put on the tongue and ask, can you taste the salt? Is it stronger or less? Doing those objective measurements, because where taste information goes to the back to the brainstem in the back of the head, is harder to assess objectively. Did I miss anything?
The other thing I'd just pick up on is about which is particularly prevalent in doing the sniffing sticks, is the alternative forced choice format, because that causes a lot of question marks. People sort of say, well, why do I have to give an answer if I can't smell anything?
Just to define what he means by alternative forced choice, meaning you get the question and you have to choose an answer. You scratch it or you sniff it, and you get onion, lemon, rubber tire, whiskey. You have to pick one. You say, I can't smell any of them. You have to pick one, or the test doesn't, the way it's computed and some of the things we can learn, it doesn't work if you don't make that choice. As frustrating as that can be, seem like you're doing something completely worthless and stupid because you can't smell any of those four things. It's just.
And I think people therefore think they're inflating their score beyond where they should be, and that's not the case, because obviously we have reference values for, even if you kind of get some right by chance, you're still still going to perform to a certain level. So that is built into the test. But particularly for the threshold test, which is a sort of in the sniffing, it's the first part of the test. Actually, as you go up the concentration gradient, because you start from the lowest concentration, you work up to the strongest smelling pen in the set. Actually, for some people, particularly those who are hyposmic, even if they can only just about get something, actually, if you give them the opportunity to say, I can't smell anything, they'll just go for the say, I can't smell anything. Actually, if you make them kind of concentrate and go, can I smell something, yes or no, I have to give an answer. Actually, when they think about it, actually, maybe they can get it, and actually then start to kind of find just about where the threshold is, and that sort of, so that can actually demonstrate that there is actually, some level of activity there. So it feels very frustrating, and obviously for people who've got absolutely nothing, the test can seem just a bit sort of chaotic. But it is a process. It's an international standard, and there is a reason why we do it.
Yeah. One other thing I'd mention about testing. Oh yeah, very very quickly. So what is accessibility to testing? Testing in the ways that Carl does it takes time. The kits are expensive, even though it can be reused sometimes. So something that a number of us are working on is trying to get much less expensive tests developed that can be just as rigorous, but that could go into any primary care doctor's office and be a part of every single person's regular wellness visit, getting baselines, looking for changes that happen as soon as they happen. And by doing it as inexpensively but still rigorously as possible, that could make this a much more accessible broadly, but also just raise attention quite a bit that this is an important part of healthcare. So that's part of it as well.
Excellent. Thank you both very much.